Good morning. It is my pleasure today to introduce the speaker of the MC2 Mayo Center Medical Series, Dr. Ray Kurzrock. I think it's very timely that we have Ray talking here. Um, our interactions continue growing. I want to congratulate Mayo and thank you for the invitation for the Functional Genomics Symposium, where we find new solutions in order to form the network with animal models for diseases and also with pharmacological development and drugability. Dr. Ray or Razelle Kurzrock. It is different. It is actually very, very difficult to put these for many people into context on how much achievements a person can make. Dr. Kurzrock is a pioneer. Her work transformed cancer care worldwide and earned recognition to her as the most influential voices in precision medicine globally. She has brought also pride to the institutions that she has worked and shaped precision medicine in, such as initially in Texas, MD Anderson, the University of California in San Diego, and now we are so honored to have her at MCW in both capacities, in the capacity of Associate Director for Clinical Precision Oncology here at the Mellowes Center and practicing at the Cancer Center. Dr. Kurzrock's accomplishments are simple and parallel. As one of the most highly cited researchers in the world, she has authored an staggering more than 1,000 publications that have expanded the frontier of scientific knowledge. She is one and has been named and honored as one of the most highest widely scientists in the world. I would say that this is the scientist that gave us precision targeted therapy and precision oncology. Her seminal discovery have been instrumental in developing 8 and continuing more FDA-approved life-changing drug. The fit, I mean, it was amazing for started with targeted therapy. As you can see, also the enormous amount of people that might have participated in this, and she has trained. She is the chair of the influential Early Therapeutic and Rare Cancers Committee, ZWOG, one of the nation's largest clinical group. The work of Dr. Kurzrock gave rise to her receiving the 2022 National Center Institute Directors Award of Merit for outstanding contribution to advancing cancer research and improving patient outcome. Why we are bringing in for rare? Why is rare? Because she is a rare individual. It's very unique what she is. She's amazing. But it's also rare because she is, like we are, intellectually interdigitating the world of rare diseases. And she created the N1 system, which is actually rare. And for that, the work that gave her the first N1 match was presented at the Nobel Symposium at the Karolinska. Personally, she has 3 beautiful dogs, which is a breed that I love. And she has a wonderful partner, Dr. Philip Cohen. Ray, it is a pleasure for both Mayo Clinic and on behalf of Mayo Clinic and the Mellowes Center, thank you for accepting the invitation.
Well, thank you for inviting me. And it's just a real pleasure to be able to speak to you. And Dr. Arrutia was a very nice introduction, but you've just done amazing work to elevate the Mellowes Center into an national, international gem. So I'm just really pleased to be presenting here. What I'm going to talk to you about is precision medicine in the era of rare. And my focus is oncology, but I think there's a lot of that we can learn across medicine from oncology. It's really a two-way street. And so let me get started. These are my disclosures. And I just want to give you a little bit of my background experience. Before I was at MCW, I was at the University of California, San Diego. And I did a lot of different things there, but the thing that was really close to my heart was I founded and directed a Center for Personalized Cancer Therapy. And before that, I trained at MD Anderson Cancer Center, rose through the ranks, and became the founding chair of the Department of Investigational Cancer Therapeutics, which did early phase clinical trials. And we really grew that to be the largest phase 1 clinical trials department, probably anywhere in the world. I've been able to oversee clinical grade molecular profiling on over 20,000 patients. And the experiences at these two institutions really informed my thinking about precision medicine, especially in oncology, but really beyond that as well. So the take-home point or points is that at the multi-omic level, every metastatic tumor is unique and complicated. And therefore, when we look at cancer patients, every patient is really rare or ultra rare, or in fact, they're N of 1. Every patient is different. And thinking of patients in this way is really just a dramatic departure from how we normally do oncology. So I'd like to walk you through what we do in oncology and where I think we need to be going. So the first thing we do when we see a cancer patient is we make a diagnosis. And the way we make a diagnosis is with an instrument called the light microscope. This instrument is phenomenal. It was invented in 1590, and 400 years later, more than 400 years later, it is still the instrument that we use to make a diagnosis. So it shows you how great this instrument is, but it also tells us that maybe it's time to dig a little deeper and move into more sophisticated ways to diagnose cancer. So the way cancer is diagnosed by the light microscope is we look at the surface of the cell, and the pathologist can tell us where the cell came from. It came from the lung, so you have lung cancer. It came from the colon, you have colon cancer. But what the light microscope cannot tell us is what is wrong with that cell that made it into a cancer cell. And so the light microscope is only giving us very limited amounts of information. And because of that, this is the traditional method of deciding therapy based on clinical trials. It is largely guesswork. In other words, we do a clinical trial and 20% of patients respond, or 30 or 40% of patients respond. They have lung cancer or they have breast cancer, but we have no way of knowing who are the responders and who are the non-responders. So one of the ways we try to figure out the best therapy for patients is through randomized trials. And randomized trials are considered the gold standard because they get rid of confounders. But if we dig a little deeper, we should be able to see that there's still a major issue with randomized trial. So if you do a randomized trial in unselected patients, let's say with breast cancer, and you randomize drug A, which hits a target that's present in about 40% of patients, against drug B, which hits a target that's present in about 20% of patients, this randomized trial will tell you that drug A is the better drug. But drug A is actually not the better drug. Both drugs are perfectly good drugs, but drug A hits the more common subset of patients. And then let's move on to drug A, and let's say drug D. Drug D hits a very a target that's present in only a very small subset of patients, but it's a really good drug for that small subset. But in the context of a randomized trial of unselected patients, drug A is going to be a much better drug, and drug D will never get approval because it hits such a small subset of patients. But it's a perfectly good drug, maybe a life-saving drug for that small subset of patients. So in the era of precision medicine, we need to move on from these randomized trials of unselected patients that don't tell us, as we think, what is the better drug necessarily, but tell us what is the drug that hits the more common subset of patients. And that's not really what we want to know anymore. So it's very important that we not be missing the target. And fortunately, in the new era, we have a really amazing instrument. I'm going to call it the molecular microscope, but it's not really a microscope. It's next generation sequencing. And next generation sequencing can look into the cell, look at the DNA, and tell us not where the tumor came from. Did it come from the lung or the colon? But tell us what exactly is wrong with that tumor that caused it to be a cancer. And by knowing what is wrong with the cancer that caused it to be a cancer, we can then treat patients. And then this is amazing technology that with breathtaking progress, unparalleled in human history. In the 1990s, it was conventional wisdom that we would never sequence the human genome. By 2001, never was over, and we had the first human genome sequence, but it took 13 years, cost about $3 billion. The price started to drop, but by about 2007, it was down to 100 million per patient to do sequencing. Still a little bit stiff for our research grants and for insurance, but now we can do clinical grade sequencing on patients in the clinic every day. The price has dropped about $1,000 per patient, and that's perfectly manageable, and we can get the results back in a few days. So this has led to the reclassification of cancer based on molecular alterations, and those alterations can be genomic abnormalities or abnormalities at the protein level, which often reflect genomic abnormalities. And these are two papers we wrote in 2014 and 2015 about HER2. HER2 protein is high when you have ERBB2 amplification. And we think about this for breast cancer and stomach cancer, which have FDA-approved drugs. But when we looked at over 37,000 patients, we found that this was not about breast and stomach cancer, but multiple other cancer types had HER2 positivity. And in fact, salivary duct cancers were probably the most commonly positive, with 60 to 100% of patients positive. So it took a decade until there was an understanding that this was really a pan-cancer marker and did not relate to a single cancer. But just about 2 months ago, the FDA now has approved the first solid tissue tissue agnostic. So that means you can have any tumor type, but if you have HER2 IHC positivity, you can give a drug that is called Enhertu that is targeted against HER2. So this is really the reclassification of cancer based on its molecular abnormality and being able to hit that abnormality with drugs, rather than classifying cancer based on its organ of origin. So if we're going to reclassify cancer and re-diagnose it based on its molecular, we need universal genomic testing. And we wrote a paper in JAMA Oncology in 2016 saying that universal genomic testing needed to win the war against cancer. Genomics is the diagnosis. Wrote another paper in Journal of Clinical Oncology, which is the ASCO journal, last year about the same issues. And hopefully at MCW, we're now trying to initiate a universal NGS initiative. So what this has led is to some pretty dramatic changes in clinical trial design, and I want to walk you through that. So we started off, as an example, thinking that lung cancer is one disease, and then we began to learn that lung cancer is many different diseases defined by their molecular abnormalities. So there's EGFR mutated lung cancer, BRAF mutated lung cancer, ALK fusion lung cancer, and so forth, and each can be targeted. And then we moved on to begin thinking about tumor agnostic biomarkers. And so let's take the example of NTRK fusions. They occur very rarely, about 1 in 300 patients. They occur in multiple different cancer types. And we began to do clinical trials where the criteria for entry was having the biomarker, having an NTRK fusion, and it didn't matter if you had colon cancer or lung cancer or brain cancer. And we were able to treat with an NTRK inhibitor, and this eventually led to two tumor agnostic approvals of potent NTRK inhibitors. And so this has meant that we've moved on from these large randomized trials of unselected patients, where only a small proportion of patients respond, and you needed the statistician to tell you which arm was better, because the differences were often not very visible, into a new era where we treat very small numbers of patients. All the work is done up front in selecting the patients. So with NTRK fusions, which occur in 1 in 300 patients, you have to screen several hundred patients to find the right patient. But then once you find those right patients, most of them respond to the therapy. So now high response rates in highly selected patients. And multiple approvals. The clinical trials that led to these are called tumor agnostic basket trials, again, biomarker based. So on May 23rd, 2013, really a breakthrough approval. This was the first tissue agnostic approval, and it was for an immunotherapy pembrolizumab for patients with MSI high or mismatch repair gene defect tumors. And this was a breakthrough for several reasons. It was the first tissue agnostic approval. It was an approval of an immunotherapy based on a genomic marker. And then probably the least known of the factors, but maybe the most important, is the approval was partially based on real world data. So the FDA opened the door to using real world data. We now have a ton of data, computerized data, again, almost unimaginable a few years ago. And the FDA opened the door to using that data for approvals. So one of the things we learned from studies with these immunotherapies is that the pillars of precision personalized medicine are genomics and immunotherapy. And even though people think of them as separately, they're not actually separate. They're a couple and they're married to each other. And it's actually genomics, which can often be used, as was used in the case of the tissue agnostic approval of pembrolizumab, to determine who will respond to immunotherapy. So these are now the tissue agnostic approvals that have happened over the last few years. This is in solid tumors, and we had 7 of them. And a few months ago, I predicted that 3 more were expected this year. And now one of those 3, which I had mentioned before, the HER2-directed approval, has occurred. There's also tissue agnostic approval for a hematologic malignancies, and that is pemigatinib for FGFR rearranged myeloid lymphoid neoplasm. So pemigatinib is a potent FGFR inhibitor, and if you have an FGFR1 rearrangement, pemigatinib, and a hematologic malignancy, pemigatinib is the drug. So that has led us through the first era of precision medicine. And but one of the things, very important thing that has happened as we sequence more and more patients is we're making discoveries that tell us that the biomarker-based tissue agnostic approvals are not the end of the road, but the beginning of the road. And what if every patient with metastatic disease is different? And what we've learned is that patients, the tumors are all different and they're all very complicated, sort of like snowflakes. Every snowflake has a different crystal structure and is very complex. And that is true of tumors too. And so if we use this example, these are next generation sequencing of metastatic breast cancer. We've done thousands of patients, but they don't fit on the slide. But I'm going to show you a few patients to illustrate a point. So this patient and this patient both have ERBB2 amplification, and they would be eligible for an ERBB2 inhibitor, such as Enhertu, which we mentioned was just received a tissue agnostic approval. But there is a problem with giving just Enhertu or a similar drug to these patients. And you can see that problem just by looking at the sequencing data. The first problem is that each of these patients have multiple alterations, and it cannot be optimal to give them just one drug when they have the tumor has many other drivers. And the second problem is just because these patients have something in common, the ERBB2 amplification, doesn't mean that they need exactly the same regimen. The rest of their alterations and their tumor are individually different. So this suggests that the patients need not a single common drug, but rather an individualized, customized combination of drugs. And historically, we have not been doing that. We give a single drug and we play a whack-a-mole game. So clinical trial designs are evolving, and the next iteration are multi-omics, not just DNA, but DNA, RNA, protein, et cetera, and based on N of 1 trials, meaning that every patient in a clinical trial is treated differently. And this means that in a clinical trial, instead of the drugs being the center of the universe, and we find patients to fit onto the trial or onto the drugs, we turn it on its head and the patient becomes the center of the universe. And we now find drugs to fit to the patient rather than patients to fit to the drugs. So this means we move from drug-centric to patient-centric, and we test a strategy, not a drug or drug regimen. So just to give you examples, in a drug-centric classic trial, you have patients A, B, and C. They all have A in common in their molecular portfolio, but the rest of their molecular operations are different, but they end up on the same drug regimen. And because we find a common feature between patients. Initially, it was the type of cancer. Let's say they had breast cancer or colon cancer. More recently, and this is a step forward, it's tissue agnostic biomarker-based clinical trials. So we find something in common. They all have NTRK fusions, or they all have ERBB2. We put them on the same regimen. But then we've moved on now to the next stage, and that's a patient-centric trial where each patient actually gets their own combination of drugs specifically for the molecular aberrations in their tumors. And this is really N of 1 clinical trial design with personalized combination of therapies. And this is why at the beginning, I talked about that the fundamental unit here is really N of 1, not even rare or ultra rare, but every patient as an addition, as an individual. And there's two major treatment approaches here, the genomic strategy and the immunotherapy strategy. And I mentioned this before, but I want to reiterate it. Genomics and immunotherapy are generally looked at separate, but there are a couple and they're married to each other. So I did want to talk a little bit about discovery in real time and the MCW strategy. We opened a precision medicine rare cancer clinic. This is a clinic based on molecular aberrations. We've seen multiple cancer types and over a couple of thousand patient visits. And every patient gets comprehensive molecular profiling, next generation sequencing, protein analysis, immunomics, liquid biopsy, functional studies, and advanced bioinformatic analysis. And importantly, we've set up the structures to be able to do this in the clinic. So we have master protocols called Predict and iPredict, so that any patient walking into the cancer center who needs this type of strategy can actually be treated and also be treated in the context of an IRB-approved clinical trial. Now, we actually started these protocols, the first iteration at MD Anderson and later at UCSD. And I want to talk a little bit about these first iterations, which were really based on just DNA sequencing. We didn't have the capacity yet to do RNA or protein or immunomics, but the trial was started in 2015. And really, I believe, was the first N of 1 trial, and called Investigation of Profile-Related Evidence Determining Individualized Cancer Therapy. Again, any patient walking in the cancer center could get this therapy. Patients had molecular profiling. The first trial at UCSD, the trial was just based on DNA. They had a molecular tumor board, and then we did our best to match the patients with drugs. And this is kind of a diagram of what we were doing. So the results were quite remarkable, and we were fortunate to be able to publish them in Nature Medicine. And what you can see is that patients that were had high degrees of matching had much higher response rates than patients with low degrees of matching. And furthermore, in these highly refractory patients that had failed conventional therapy, patients with high degree of matching, over 60% were alive at 2 years. In patients that had lower degrees of matching or were unmatched, less than 20% were alive at 2 years. And so really, I think this was one of the first trials that treated patients as an individual. And one of the questions that comes up is, if every patient gets a different drug regimen, what is the endpoint? How do you evaluate it? And the answer is, you don't evaluate the drug regimens in different diseases. You analyze and approve how robust is the algorithm, not the individual drug combinations. You want to know how good is the algorithm for matching. So it's really a very different approach to clinical trials and practice. I predict, after it was published in Nature Medicine, it was featured in the Future of Medicine National Geographic magazine and NIH Director's blog. And I was really honored to be asked to speak about this at the Nobel Symposium at the Karolinska in Stockholm last September. So I do think that this is potentially transformative. So one of the problems with giving individualized drugs to patients is, how do we dose them? How do we know this is safe? And since I founded and led at MD Anderson what was really the largest phase 1, I'm very familiar with phase 1 studies that establish how you can give drugs safely in combination to patients. And I want to say that the classic paradigm, we need to depart from it. So in order to give novel combinations of approved drugs, we need to do something different. And One of the reasons we need to do something different is because when you classically do phase 1 trials, you figure out the dose in a very small number of patients, often about 6 patients. And those 6 patients, you figure out the dose after they've been on therapy for a month. So this is our classic way of establishing safety. And for individualized combinations, we just cannot do a phase 1 trial for everybody. And besides that, establishing dosing and one size fits all for everybody on a small numbers of patients is probably not optimal regardless. And there's a more important problem, and that's that if you need a phase 1 trial for every combination, let's just think about this. Let's say there are 300 drugs in oncology. The number of 2-drug combinations is about 45,000, and the number of 3-drug combinations is about 4.5 million. So we cannot do a trial on all of these combinations. Take us over 1,000 years to figure this out. So we really needed a different way to figure out how to dose patients safely. And I'm just going to walk back and say, and we also needed a different way to do this, because if we think about it, even though this is how we've always done it, it doesn't make a lot of sense. We give everybody the same dose. And that means that this elderly, frail man with cancer gets the same dose as this young athlete who also has cancer. And I don't think you need to be a physician to know that that's probably not the right thing to do. And then what dose does she get? So in order to figure out not only how to individualize drugs, but how to individualize doses, we did a study with one of my fellows who's now faculty at UCSD, looked at 100,000 patients in the literature and developed some general rules for how to dose patients safely. And then what we did is we found the best dose for every patient through intra-patient dose escalation. In other words, we started patients at lower doses, we saw the patient in clinic weekly, and then we dose escalated to tolerance. As we were doing this, we found that it was perfectly safe, and we've done a couple of hundred combinations now that have never had a phase 1 study done. We've seen that this is perfectly safe. And then I'd go even beyond that and say, even for those regimens where there has been a phase 1, this way of figuring out the best dose for each patient is probably better than the way that we've classically done that by giving everybody the same dose. So then I'd like to move on and say that beyond molecular matching that is individualized and personalized dosing, we need to realize that genomics is just the tip of the iceberg. We started with genomics in the context of precision oncology because that was what was clinical grade and what was available to us. But now we have many more tools at our disposal. We have transcriptomics that is clinical grade. We have immunomics, proteomics, and developing metabolomics and epigenetic changes to be able to look at in the clinic. So this is really a new era of moving beyond just genomics, but to multi-omics. Now, we were able to conduct a study, the first study, I believe, with using not just genomics, but also transcriptomics. This was conducted through the Worldwide Innovative Network, WIN, for personalized cancer therapy. And the winter trial was an N of 1 trial that included a genomics arm and a transcriptomics arm. It was conducted at 6 centers in 5 countries. We published this in Nature Medicine. And the bottom line is that in this first precision medicine trial that included both transcriptomics and genomics, we found that the transcriptomics substantially added to the information that we were getting from genomics, and it further moved the field forward by having this information. So I want to give you some examples of patients and just give you examples of things that we do. This is a 62-year-old man with a poorly differentiated carcinoma of unknown primary. A carcinoma of unknown primary means we don't know if it comes from the liver or the lung or the colon, because looking under the light microscope actually doesn't tell us where it comes from. So about 5% of tumors are called carcinoma of unknown primary, or CUP, and this patient had one of those. So this often really bothers oncologists, not knowing where the cancer came from. But for us, since our diagnosis is molecularly based, it really doesn't make a difference. Now, this patient didn't have enough tissue to do next generation sequencing. So we did a liquid biopsy. We looked at the blood and we looked at circulating tumor DNA, and we found that the patient had an unusual KRAS mutation, but it was activating. And the patient had an ARID1A alteration, which is a chromatin remodeling gene. And we know that KRAS activates the MEK pathway. So we gave the patient trametinib, which is a MEK inhibitor, and ARID1A is a chromatin remodeling gene. It does a lot of different things, but one thing it does, one of the things it does is it sensitizes tumors to PARP inhibitors. So we gave the patient a PARP inhibitor called olaparib. In other words, we gave a customized combination of drugs. And I think you can see here that the patient had a beautiful response to this therapy. And this is at 16 weeks. And this response lasted for about 2 years. Now I'm going to give you another example, completely different example. Fibrolamellar cancer. This is a very rare cancer. It is a liver cancer, but it's not like typical liver cancers that occur in older people that are alcoholics. This is a liver cancer that occurs in young people, teenagers in their 20s and early 30s. It has a DNA JB1 PRKACA driver fusion that is not druggable. So this really, fusions are drivers, and what do you do if it's not druggable? So what we did is we exploited multi-omics and bioinformatics, and we can now do this in real time. We don't have to wait a couple of years. Patients can't wait a couple of years. You don't have to write a new protocol, because we now have protocols that are umbrella protocols that allow us to do this. And this patient we published because she had a great response. And she actually went into complete remission, which is the time we published it was ongoing at 2 years, is now ongoing at almost 4 years. And she had a response, a complete response to a combination of immunotherapy. And we figured this out through transcriptomics and bioinformatics. And this was completely non-intuitive. Remember, she had an undruggable DNA JB1 PRKACA fusion, but more than that, all her classic biomarkers for immunotherapy were negative. So she had a low tumor mutational burden, she had a PD-L1 negative, and even more amazingly, she had already failed a related immunotherapy. So this was completely non-intuitive, but bioinformatics and looking at transcriptomics actually gave us the answer. She's been all over the internet, but you can see she's a young woman. She was told to go to hospice because she had failed everything. And she is now, as I mentioned, almost 4 years complete remission, probably cured of the disease. So how do we approach undruggable fusions? This has been a real conundrum, but this is our approach. We look at RNA expression for targets. That's one way. We perform immunomic analysis because maybe immunotherapy might be the right way to approach this. And we look at the protein. We do an immunohistochemistry panel, and we can use drugs like antibody drug conjugates and other similar drugs based on the proteins that are found on the surface of the cell. So again, this is all about doing molecular testing on everybody and getting the right drugs, the right patients at the right time. So I'm going to wrap up by talking about looking into the future and where I think this is going. I think the molecular tumor boards are going to remain extremely important in synthesizing data and complexity. And in addition, it will be very important to have master studies that allow discovery in real time for the patients that are in front of us, and that allow us to treat them with understanding their tumor DNA, RNA, protein, and so forth. And the future is in looking at tumors based on their molecular abnormalities, not based on their tissue of origin. Now, there are some fascinating things that have come out of this that really go beyond cancer, and I'm going to give you this example. There's a lot of these examples, but this is an example. So there is a gene called FGFR3, and FGFR3 is found in a lot of different cancers, but it's found in bladder cancers. It's known to be found in bladder cancers. And we now have a few drugs. One of them is called erdafitinib and other similar drugs where we can target this gene abnormality. It's a kinase enzyme that's abnormally activated, and we can treat patients with these cancers. Now, what is fascinating is that patients with achondroplastic dwarfism had the exact same gene abnormality, not just the exact same gene, it's exactly the same mutation. And this is fascinating for a few reasons. In this case, even though they have a gene that in the somatic form is associated with the development of cancer, achondroplastic dwarfs do not have an increased incidence of cancer. So one of the fascinating things is, what is the protective mechanism where they don't get cancer, even though they have a gene that is clearly oncogenic and it's germline? And then the other question is, could we reverse the phenotype of achondroplastic dwarfism by giving them the inhibitor that is already approved for patients with cancer? So this has been done in mice studies of achondroplastic dwarfism, and it has worked. And there is now a clinical trial with one of the FGFR inhibitors called infigratinib. This trial just started in December 2023, and we will see if this drug is usable beyond cancer. Now, I think it's important to remember there are about 7,000 rare diseases and about 350 million patients worldwide with a rare disease. And so the ability to exploit drugs developed in one field for other fields, I think, will be extremely important. We recently published this paper in one of the Cell journals, Reverse Repurposing, the Potential Utility of Cancer Drugs in Non-Malignant Illnesses, because it turns out that a lot of non-malignant illnesses have mutations in genes, and those mutations are, like for achondroplastic dwarfism, the exact same mutation that drives cancer. And so this is a figure from the paper, but it shows just a few examples, like amazing examples of where drugs that are approved and used for cancer can counteract mutations in diseases that have nothing to do with cancer. And then just looking into the future, this is Precision Medicine in 2033. And this is where I see things going. You come in and you have a disease. We do same-day multi-omic testing. We do in silico modeling to decipher the abnormality and what compound is needed. And we instantly create the compound through 3D printing. So again, this is not something we can do today, but I think it is in the future of drug development. So I'm going to end there. And my first thanks is to all the patients that we've had the honor and privilege of trying to help, and precision medicine team, and to Dr. Aruscio and the Mellowes Center for enabling us to do this work. So I'm just going to stop and let me know if you have any questions.
I actually think that I continue being just impressed, and not only in the paradigms, but how some of the things that we have been thinking in the discovering phase, you have operationalized, you have made them operational, and you have to do the experiment as well. The clinical investigation, let's put it that way. And you are getting, I mean, we are getting this way, and you're getting this way. And it's remarkable because we are looking exactly at what you have done in a sense. We are looking at we know that cancer research or cancer targeted therapies will improve our ability to look at repurposing drug. And we also think that your paradigm is a multidimensional paradigm that sometimes we use in rare and undiagnosed diseases, but I actually think that we can learn even more from the precision oncology. I think, in particularly drugs and things like that. So I actually think that this is truly paradigmatic. It changes it. I think that the future, one of the questions that I want to tell you is that we at the Mellowes Centers, as you might see, are doing a large amount of molecular pathology on paraffin-embedded tissues.
Mm-hmm.
And the reason for that is because of our international collaborations, and so they send us, the point is for them to send us the tissues, right? And we just do we do that. So we not only do whole genome sequencing and whole exome sequencing from there, but we do a spatial genomic now as soon as the single cell resolution is spatial. And it would be great to do some of those, to repeat some of your question. I'm sure you might be doing it, but in case, we should be talking about applying some of those. Next year, if we are capable, we are seeking to buy the new machine that will do both genomics and proteomics in the same. So it's a wonderful, I guess, advance.
Yeah, so we would like to continue to build on a collaboration with you. And I think that what you're doing in the Mellowes Center is amazing. And especially with the protein, where we don't have a lot of abilities yet in the clinic. I really enjoy it when you come to the molecular tumor board. We would welcome additional people for the Mellowes Centers there. And I think building on these collaborations, I've been amazed when we've talked, we have common interests in chromatin remodeling genes. We both love Basenji dogs, which is amazing because they're such a rare breed. So
Well, we'll
I
do
would
it for
really
sure.
love to, yeah, I would really love to build
Yeah.
further on these collaborations.
Well, you will be critical also for this seminar, for the MC2. And the reason from our colleagues at Mayo, and please prepare questions, is that we are having with Mayo and Dr. Cleese and Dr. Lambert and the other Dr. DeViro are not here today for different reasons, but we just had, we are forming a network of functional genomics because in reality, this center was formed with the slogan Beyond the Base Pair. But, you know, Mayo has actually invited us. We just came back from the symposium. Beautiful symposium, by the way, colleagues, on functional genomics. We are with the University of Minnesota, and we are with Arizona, and we are integrating other people. And then we have animal models and different things. So we are looking forward to certainly have you to look into this. Our colleagues here at Mayo and us are trying to build first the Midwestern network, and in terms of functional validation by rare diseases and rare cancers. So whatever you would like to eventually bring, but we will collaborate with you as well in that regard. Michael, you want to say something? Or anyone in the audience?
And then there's also, I don't know if Michael has a question, but there's some questions in the chat, and I'm happy to
Good.
address the chat questions as well.
Please, please.
Voice. That's exactly what I was coming on to voice. So if you want to, I can read them, or if you'd like to just go through them, Dr. Kurzrock, either way is good. But I did notice that you had one case that was a RAS and a BAF mutation together, which, as you mentioned, the theme of the chromatin regulators, I think there's definitely some potential to follow up together on those. Do you want me to summarize the chat questions, Dr. Kurzrock, or
if you want to, you can read them. The first question
Sure.
it's like from Lucinda Harris, and if you want to read them, and I'll try to answer them one at a time.
Yeah, the question is whether pharmacogenetic testing has been helpful for finding individual dosing.
I think that's a really good question. There are examples where pharmacogenetic testing is very helpful. There are some drugs that we already have basically in the guidelines that you should do testing. It's often not done, but where we know that if people have certain variations in their genomics, they may be very sensitive to certain classic chemotherapy drugs, or they can even have life-threatening reactions. So I do think that pharmacogenetic genomic testing is important. We don't do enough of it and needs a lot more exploration.
Absolutely. Another question is, how have you gone about ensuring that patients can have access to off-label therapies, and how often is that a barrier or a challenge?
Yeah, so that's a really good question. The approach that we took at UCSD was that we hired a magician. So it's kind of a joke, but not really. So that was, if you can have a really good idea, but if you can't operationalize it, it doesn't mean anything. And one of the things we realized was we could have great ideas of what we should be treating with, but if we couldn't get the drugs, we couldn't do it. And even though I had run this very large clinical trials program at MD Anderson, which is very, prestigious institute. So I did have some influence with drug companies. There is no way that I could mediate every drug company agreeing with their lawyers to give drugs combined to other drug companies. That wasn't going to happen in my lifetime. So we needed another method. And what we did is we hired a medication acquisition specialist. And she figured out how to get drugs legally. So there are many actually programs to get drugs in this country and to get medications, and those programs are growing. But the physician in the clinic cannot really do it. So this specialist helped us, and she was able to get probably about 90% of our drugs really very quickly within about 2 weeks. And then not 100%, but 90% is something that we could definitely live with. When I came to MCW, one of the things I liked about MCW was MCW already had a program in place. Now, it wasn't quite as good as the UCSD medication acquisition specialist, but MCW did agree to hire her as a consultant, which we had her as a consultant for a year. And I think our program, at least in the precision medicine clinic, is really world-class now. I think we probably can get about 85% of the drugs that we want at this point.
It's remarkable. To me, that seems like a very remarkable achievement.
Right.
That's wonderful. So again, thinking about in the rare disease space, and where can we take some of the lessons learned from rare disease and bring into cancer, and from cancer bring into rare disease. So I think again, I'm thinking about as we get in toward being able to identify potential therapies in some of the rare diseases, translating that function, that lesson learned over, will be very impactful. There's another question that I think what they're getting at is, you're showing some examples of what would have been regarded as a non-druggable cancer, and using immunotherapy, some examples of that having great effect in that setting. That you talked about the marriage between precision and immunotherapies. I think one of the questions here is getting at, are there examples of taking a non-druggable cancer and, again, using the two together, or, finding other precision targets?
So I think that's really what we're doing almost every day in the clinic at this point. I gave the example of the undruggable fusions because we see that all the time. And so we're not able to get from hospice to cure in everybody, or even in most patients, but there is a fraction where we can get there, and it's because we're circumventing the fusion. We're looking at the RNA, we're looking at the protein on the surface. Can we target it with an antibody drug conjugate? We're looking at the immunomics, and we're trying to figure out would immunotherapy works. And we're using very sophisticated bioinformatic techniques, and we're able to do this in real time. Patients can't wait. They certainly can't wait 2 years for you to set up a clinical trial. So we're able to do this in just a few days. Is it perfect? Absolutely not. It's a growing science. But I think that this is the right direction. There's also a question about resistance clones. Well, this is exactly what we're trying to do. Instead of hitting one driver, we're trying to hit all the drivers there. We're trying to hit all the drivers by doing a customized combination, rather than the classic of we hit one driver and then the patient develops resistance through new clones emerging. Again, can we do this perfectly? No, but I do believe that probably we're doing this as one of the more advanced levels where we try to hit every important driver at the same time.
Does that I recognize we're after the hour, so Dr. Kurzrock, if you have a minute yet, does that matter in your mind how subclonal it is, or do you really want to try to hit everything that you can identify that you think is an actionable driver?
I think it's a great question. And one of the things when we looked at the paper, the patients in the paper that we published in Nature Medicine, it's a question that comes up several times. And that's just the variant allele fraction, the percent matter. So there'll be, there'll be mutations that are found at a very high variant allele fraction, and then there'll be mutations that are subclonal or at a smaller variant allele fraction. My gut feeling was, of course it matters. Then we did a data analysis, and it didn't make one bit of a difference. But then we looked at it statistically, in a close, more closely, and we found that there was only a small number of patients that we had targeted that had outlier variant allele fractions. And when we had our statistician look at it, he told us that probably with the data we have, we couldn't find a difference. Not that there wasn't a difference, but the data wouldn't reveal the difference. So this is a question that I think is really important. We just have not had the data to answer the question, and we elected not to publish that paper because, again, superficially, the answer was it doesn't make a difference. But when our statistician told us that with the data we have, we wouldn't be able to find the difference, we said we're just going to hold off until we get enough data where we can do an adequate statistical analysis.
Absolutely, that's the way to do it. I mean, if it is not there yet, but it will be there, because actually we have gotten to the end of this wonderful feast. Ray has given us again once more a gift for both for our Mayo clinic colleagues and for us. NC2 squared, as we call it, Mayo plus Mellowes, and we can more to the square. I think that there is a lot of achievement to be proud of, and we will continue. Remember that we soon will have more symposiums that are wider, but we'll continue with this wonderful series. Ray, we are so grateful for this wonderful, paradigmatic, and life-changing kind of talk. Okay, thank you so much.
Thank you for having me, and it's really a pleasure working with you.
Thank you.
You take care.
We'll be in touch. Thank you. Bye-bye.
Bye-bye.